We're next moving to looking at hemostasis, which is the arrest of bleeding. Depending on the text you look at, it can be broken down into 3 or 5 stages. But ultimately, we're interested in considering the role of platelets and other blood components and proteins that allow for the arrest of bleeding and clotting to occur. So we'll be taking a look at the physiology and then pathologies as to when this goes wrong. Hemostasis is triggered by injured tissue. Injured tissue releases chemicals that are going to start this mechanism of hemostasis. The first step is called vascular spasm, and it's mediated by the nervous system and also prostaglandins. The smooth muscle of a blood vessel is going to constrict, and that's going to reduce blood flow. The second step is the formation of a platelet plug. So platelets are activated by cytokines and by contact with collagen. If a blood vessel is injured and there is a gap in the endothelial cells, the underlying collagen in the connective tissue will be exposed, and that can activate the platelets. The activated platelets become sticky and they attract to one another and they form what we call a platelet plug. Our third step is coagulation, or the development of a clot that is triggered by insoluble fibrin, and it forms a network of mesh that hold more platelets together. So it almost looks like a spider web that the platelets get caught in. After the clot has formed, the next step is clot retraction, which is going to pull the sides of the broken blood vessel closer together. And then the last step is clot dissolution, which is where the clot will start to resolve, and it places a limit on how large the clot is going to build up to. So we'll take a look at each of these steps in a little more detail. So we'll first be looking at that platelet plug formation. So here we can see is a damaged blood vessel, and underneath the blood vessel, so these would be the endothelial cells, we can see that there are collagen fibers. So this disrupted endothelium is exposing the collagen in this subendothelial space. So the platelets can adhere to the collagen, and that activates them. And when they're activated, they're going to start to release mediators. Mediators are thromboxane, ADP, serotonin, etc. And they activate and recruit more platelets into the area, and it starts to cause them to aggregate together and block the damaged area. So those chemical mediators, some of them are listed here. So you can see thromboxane A2, ADP, serotonin, etc. Let's take the first one. So thromboxane 2A, it's a prostaglandin. These mediators are going to attract and activate more platelets. It's going to start to form, as more and more platelets come into the area, a platelet plug. And it's important to note that the platelet plug is different than a blood clot. So we're first going to examine the specifics of platelets, and then we'll move to coagulation. So here's a platelet in more detail. At the top, they're depicting for us what we call a GP2B3A glycoprotein. It's important for allowing platelets to bind to each other, and it also allows platelets to bind to fibrin. There are enzymes present to make the chemical mediators for platelet attraction and activation, like the prostaglandin thromboxane A2. Platelets also contain granules. So if you take a look inside, you can see granules. These have chemicals stored in them important for hemostasis, also for vasoconstriction, and even growth factors that can be secreted then and allow the endothelium to start to repair. The last step of hemostasis is blood coagulation or clotting. It's triggered by coagulation factors from the plasma that are in the plasma as what we call procoagulants or proenzymes. And the procoagulants are enzymes then that have to be activated. So the cascade of coagulation factors ultimately convert what we call prothrombin into thrombin. And the best way I have of describing thrombin is that it's like scissors. It's going to cleave fibrinogen, which is soluble, into insoluble fibrin. And once that happens, then this fibrin, like its name denotes, it's fibrous, it's stringy. It's going to provide a structure for our platelets to bind to. And picture it like a spider web. The platelets are going to be like stuck, like bugs in a spider web, and they start to form a clot. This figure also illustrates another important point. So just like there are many activators that lead to clot formation, there are inhibitors that inhibit clot formation. These inhibitors are present in the blood as well, and they are there to stop the formation of clots so they don't become pathologic. One of the important inhibitors is heparin, which is also given as a drug to stop clots from getting larger if somebody does have a thrombus or a embolism. If we look at the coagulation cascade in more detail, we can see that there are multiple factors that must be activated. That's why it's called a cascade. It's sort of like dominoes tipping over. One activates the next, etc. And so these are named by Roman numerals. They don't necessarily start with 1, so they are hard to keep track of. But the last one that is important is 10, and we'll talk about it in a moment. So the factors are all made by the liver, and they're always present in the blood. The clotting factors depend on the presence of vitamin K to be manufactured properly. So to make sure that they're not causing abnormal clotting when there's no injury, they're present in the blood in an inactive form. So it takes an activating event to start the cascade to make a clot. And there's 2 types of activating events. The first is an intrinsic system that's also called contact activation pathway. And it's a slow process where the factors found in the blood or in the injured vessel cause the platelets to degranulize. For example, blood in a non-treated test tube will clot because of this intrinsic pathway. The second pathway is very fast. It's called the extrinsic system or the tissue factor pathway. Here, a tissue factor called thromboplastin is released from injured tissue. So ultimately, either pathway, once the cascade is started, they converge on factor 10 that leads to the activation of thrombin, which converts fibrinogen into fibrin, and that is going to help our blood clot to form. So after a clot forms, there are 2 important processes that take place. So the first is pictured here, and it's clot retraction. This occurs within the first hour after a clot has formed. So the platelets are adhered together and to fibrin. Inside the platelets, there are filaments like actin and myosin. It's very similar to what we have in muscle. Those filaments will contract and they bring the platelets closer and closer and closer together, and also closer to the fibrin. And what that's going to do is it's going to squeeze serum out of the clot, and it will bring the sides of the broken blood vessel closer together. The final step or process is called fibrolysis or clot dissolution. So similar to making a clot, a series of activators and inhibitors are going to play a role. Clot dissolution is very important for healing and also for inhibiting the positive feedback loop that is clot formation. So the thrombin that cause clotting to occur actually also starts its dissolution. So the proenzyme plasminogen will be converted to its active form, plasmin. Plasmin can digest or break up fibrin. The plasminogen activators are enzymes made by the liver and also by the endothelium. We can now produce these fibrinogen activators via recombinant DNA technology, and we can use them to treat diseases caused by clots, like myocardial infarctions or heart attacks, strokes, and pulmonary embolism. When we discuss hypercoagulability, it's important to understand the vocabulary of thromboembolisms. A thrombus is a clot that develops and persists in an unbroken blood vessel. A thrombus is dangerous because it can block the circulation of blood, and that can lead to tissue death. A common type of thrombus is called deep vein thromboses, or you'll see that abbreviated sometimes DVT, and that generally occurs in the legs. An embolus is a thrombus that breaks away and is freely floating in the bloodstream. Because of its organization in the vasculature, most embolisms end up in the lungs, which is why you commonly hear of pulmonary embolisms. The reason is as the veins merge, as they work their way to the heart, they get larger and larger. So it's easy for a clot that has formed to keep moving into a larger and larger blood vessel. They can easily move through the chambers of the heart, and the vasculature doesn't start to get tiny again until we go up through the pulmonary artery and make our way into the tinier blood vessels in the lungs, and that's generally where they get stuck. Pulmonary embolisms are dangerous because they can impair the body's ability to get oxygen into the bloodstream and then to get carbon dioxide back out. You'll also hear of cerebral embolisms, and those are embolisms that have traveled to the brain's vasculature. Those can cause strokes, which are ischemic events in the brain. Thrombocytosis is an example of a hypercoagulability associated with an increase in platelet function. In thrombocytosis, there's an increase in the actual platelet count, and it can be a primary disorder, meaning that there is an increase in signaling to the bone marrow stem cells that give rise to the megakaryocytes, which cause them to proliferate. And remember, those are the cells that create platelets. Or it can be secondary, in which there is an increase in thrombopoietin hormone. And that, remember, is the hormone that can trigger platelet production. That can occur from surgery, infection, cancer, or even chronic inflammation disorders. Hypercoagulability states can also be from an increase in clotting activity. Here again, it can be primary or genetic in nature, or secondary or acquired. Secondary factors result from either an increase in procoagulation factors or a decrease in the anticoagulation factors. It's associated with blood not moving through the vasculature, or what we refer to as stasis. So immobility, bed rest, myocardial infarctions, cancer, oral contraceptives, smoking, and obesity are all risk factors. Anticoagulants can be given prophylactically or as a treatment for a clot. So a thrombus can form in either the arteries or the veins. Arterial thrombi are associated with conditions that disrupt our normal blood flow and cause endothelial damage, which trigger platelet adhesion and aggregation, like in arteriosclerosis. So atherosclerosis is the narrowing of an artery due to plaque buildup in the vessel. A venous thrombi is triggered normally by stasis of the blood flow that allows the procoagulants to concentrate in one area. So they're not going to be diluted, and they'd have less opportunity to come in contact with inhibitors of coagulation. And so that stasis of blood, where it's just sort of pooling together in an area, that's what leads to the clot. The opposite of hypercoagulability then is bleeding, and we do have different types of bleeding disorders. A bleeding disorder is caused by a decrease in the number or the function of any of the factors involved in hemostasis. So that includes the platelets, our coagulation factors, or even the blood vessel structure. So we're going to briefly cover 3 bleeding conditions: thrombocytopenia, DIC, and hemophilia. Bleeding disorders generally affect the microvasculature in the skin and mucous membranes. So that's the nose, mouth, GI tract, uterus. In this image, we can see what we call cutaneous bleeding. So these tiny dot hemorrhages are called petechiae, and the larger purplish and bruised areas are called purpura. Thrombocytopenia is a condition resulting from the decrease in the number of platelets from either a decrease in production, an increase in their destruction, sequestration in the spleen, or even blood loss. So it can cause generalized bleeding. And there are different types of thrombocytopenia with differing causes. So if we take a look at these, in drug-induced immune thrombocytopenia, the presence of certain drugs can cause immune complexes to form, and those trigger complement lysis. So remember the complement system that helps to destroy bacteria. That same system then can lyse the platelets, and that decreases their number. In heparin-induced thrombocytopenia, again, the anticoagulant drug heparin can trigger an immune response and an antibody that can activate platelets. So the patient is being given an anticoagulant because of a clot or the possibility of clot formation. So with the increase in platelet activation, the clot either enlarges or new ones might form, and that's going to sequester platelets and start to lower their number. Lastly, we have immune thrombocytopenic purpura, and that's when antibodies form against platelets and destroy them. It can be primary, as in an autoimmune disease, or it can also be secondary, triggered by an infection. Our next disorder is disseminated intravascular coagulation, or you'll see it abbreviated DIC. This is an interesting disorder because we see two different things happening. We see blood clots forming and also hemorrhage at the same time. So what happens is that patients can present with petechiae, bleeding at a wound site, or from the different organ tracts in the body, like the GI, urinary, or reproductive tract. We also see that they have cyanosis sometimes in the limbs. And what's occurring is that blood clots are being formed, and at the same time, hemorrhage can occur. So how that happens is that as blood clots occur, they start to use up coagulation factors and platelets. While at the same time, remember, the clot dissolution track is activated. So we start to see fibrinolysis. Now, the dangers of disseminated intravascular coagulation are ischemia to the tissues and organs because of blocked blood flow, and also blood loss because of the hemorrhage. So there's a number of causes that can lead to disseminated intravascular coagulation, and we can break them into two categories. So the first can be because of tissue injuries, obstetric complications, malignant neoplasms, infections, trauma, surgery, burns, even hypotension. From endothelial cell injuries, you can see some of those similar things. Infections can trigger it, immune complex depositing in different tissues, burns, hypoxia, acidosis, shock, vasculitis. They lead to the activation or expression of tissue factor, factor 12 activation, and then ultimately platelet activation. That will lead to thrombin generation. And if you remember your cascades properly, so thrombin generation is going to lead to our coagulation because ultimately it leads to the generation of fibrin. The fibrin that forms is going to cause occlusions, or they block blood vessels. And the result of that can be ischemic tissue injury and even hemolytic anemia. At the same time, our anticoagulant or fibrinolysis is activated. So plasmin gets activated. And that's going to inhibit our platelet aggregation, fibrin polymerization, and thrombin. And so those steps then lead to bleeding or hemorrhaging. And also remember, as we are forming clots, at the same time, we're using up our clotting factors and our platelets. So the treatment of disseminated intravascular coagulation is basically supportive. So we have to address the underlying cause or trigger of the disorder. If a patient is hemorrhaging, plasma, platelets, red blood cells can be given to try to reestablish hemostasis. In some cases, anticoagulants would also have to be administered along with blood transfusions to help the patient. The last bleeding disorder we're going to consider is hemophilia. And this is a genetic diseases, and there are different types depending on which clotting factor is affected. So types A and B are X-linked recessive, and von Willebrand disease is an autosomal dominant in its inheritance pattern. So the mutations cause deficiencies in the different clotting factors within the coagulation cascade, and so that cascade is disrupted, and then bleeding can occur. For patients, the bleeding can be spontaneous, or if they have an injury, then the bleeding can be prolonged. They can exhibit hematuria, which is blood in the urine, epistaxis, which is nosebleeds, or hemathrrosis, which is bleeding into a joint. So depending on the patient and the type of hemophilia, the disease can be treated by replacing the deficient clotting factors or being given drugs to stimulate the proliferation of the factor, as we see with the von Willebrand disease, or it can be given anti-fibrolytic therapies.